online teaching program for postgraduate in pathology. Today, we have slide seminar on endoscopic biopsies, upper gastrointestinal tract. And for that, I would like to welcome Dr. Annie Samraj, Assistant Professor, Department of Laboratory Medicine and Pathology, Division of Gastrointestinal and Hepatic Pathology and Autopsy Pathology, University of Washington, United States. Welcome, ma'am. And we have a webinar host, Dr. Anita Bojes and Dr. Sumit Gujral. And we have students who will be directly interacting with the speakers. So students, please introduce yourself.
Hi, myself, Dr. Arya, Govindam Medical College from Trivandrum, Dept.
Hi, myself, Dr. Shukpreet, third year resident from Government Medical College, Patiala.
All, myself, Dr. Uday, third year College and Hospital, Aurangabad, Maharashtra.
Hello everyone, myself Dr. Anaf Sayyada, second year resident from Medanta Medicity Hospital, Gurgaon.
Good evening everybody, myself Daksha Shetty. I'm a second year resident. I'm from Kasturba Medical College, Bangalore.
Good evening everyone, myself Dr. Shubham Mittal, second year resident, EPS Government Medical College, Khanpur Kala, Sonipat.
Good evening all, I'm Dr. Nisha Kataria, second year resident from Hamdard Institute of Medical Science and Research, New Delhi.
Good evening, everyone. I'm Dr. Mino Chandran, third year resident, Dr. SMCSI Medical College, Trivandrum.
And as a moderator, I am Dr. Kaniyappan, and I have Dr. Shweta, who will be moderating the session. These are a few reminders. And a kind request to the attendees is not to request for annotation to the presenters. And if you have any questions or comments, you can put it in the chat box. These are standard disclaimers. Small announcement about upcoming talks. Next, we have a talk on inflammatory bowel disease by Dr. Siddharth Dattagupta on 13th of February, and on 15th of February, we have a slide seminar on endoscopic biopsy, lower gastrointestinal tract by Dr. Sanjeev Das. So with that, let's begin today's session.
Hi everyone, thank you so much for the welcome, Dr. Kaniyappan, and welcome to all of the residents participating in the seminar today. So this seminar is geared towards early learners, so residents in pathology, and feel free to type your questions in the chat, and our residents will speak for you. They will ask questions about the cases, and once they finish their description of the cases, then we will open it up for discussion, and I can take some questions in the chat. So let me start sharing. Oh, and before I start, so I a little bit about myself. My name is Annie Samraj. I started my medical education in India. I did my MBBS at Christian Medical College, Vellore, and I did my MD residency in pathology at University of Washington, and my GI pathology fellowship and surgical oncology fellowship at University of Washington as well. And I've been faculty here for the past 3 years. So I'm quite excited to start this seminar. I'll share my slides now. All right, so here we have our first case. So, we will go through the basics of normal histology first, and then we will go into the cases, the actual cases. So I believe we have one of the residents who will start describing this first slide. Daksha, was the normal histology was assigned to you?
Yes, ma'am.
Okay, do you want to start describing?
Yes, ma'am. Typically, we are seeing 4 layers here. So the first layer is the mucosa, which we are seeing. So this is usually stratified squamous epithelium, which is non-keratinizing type, and the second layer, what we are seeing is the lamina propria and muscularis mucosa. Both we are seeing. So lamina propria is these are the which are loosely connective tissue layer. So these are lamina propria, and muscularis. So this is the lamina propria which we are seeing here. So the down which below the lamina propria is muscularis mucosa. So these smooth muscle cells, smooth muscle bundles, what you're seeing here is the muscularis mucosa. So next is below that is the submucosal layer. So here we can see dense connective tissue, blood vessels, and lymphatic vessels also. Sometimes we can see glands also. So
Yes.
And the last layer which we are seeing is inner circular muscles and longitudinal layer, outer longitudinal, and this is the inner
Yes.
circular layer, and the down is the outer longitudinal layer.
Yes.
And also the last layer we see is adventitia. So this is the adventitia what we are seeing.
Yeah, that was really nicely well described. Thank you, Daksha. So I just wanted to quickly recap. So, the tubular gut, so we're talking about the esophagus, the stomach, the intestines, all of them have a somewhat, similar organization. So usually we have 4 layers. So we have the mucosa. So the mucosa is actually not just the epithelium. We have the epithelium, we have the lamina propria, and then the muscularis mucosae. So the mucosa consists of these 3 components. So this is the up to here, the muscularis mucosae is the mucosa. Then below that is the submucosa. Then we have the muscle layer. And in between the muscle layers, we also have the nerve plexuses. So here you can see a large nerve bundle. And what do we see here? Do you see this? We have this structure here. And when you take a closer look at this structure, what are these structures, Daksha?
Ganglions.
Yeah, exactly. So these are your ganglion cells. And so notice how here, we have this, it looks very much, it reminds you of neural tissue. And then we have these large cells with basophilic cytoplasm, and they have pretty large, somewhat scary looking nuclei. And the reason I point this out is because sometimes, if you're not aware of this here, then it looks a little bit scary from low power, right? You might be wondering, okay, is there a carcinoma? But no, these are just our ganglion cells and intervening nerve plexi. So you see the nerve plexus here. And the important thing to remember about the esophagus is that it does not have a serosa, right? So a serosa, how is a serosa different from the adventitia?
If it is the external layer, if it is present inside the peritoneal cavity and it is lined by mesothelial lining, then we call it as a serosa. And
Exactly.
Above the peritoneal cavity, it is called as adventitia.
Exactly, yeah. So, and the thing is, so the adventitia lacks a cellular barrier, right? So here you see, there's ink over here directly on the connective tissue. There is no mesothelial lining. So the lack of this mesothelial lining means that if there is carcinoma, if your neoplasm has infiltrated all the way beyond the muscularis propria, because there is no barrier, there is extension into the lymph nodes, it has easier access, so it has a potentially easier route of infiltration. So that's one thing to remember about the esophagus. And it has these 2 muscle layers, and in the stomach we'll see that it has 3 muscle layers. So esophagus has only 1. And another thing that I want you to notice is that in the lamina propria, So in the mucosa and the lamina propria, notice how we have small vessels. We have only these capillaries lined by a single layer of endothelium. And then on the other hand, if you come down to the submucosa, notice how we also have these larger, thicker vessels. So here is a vein, and this one also has a thicker wall, and then here is an arteriole, here's another arteriole. So submucosal vessels are larger. And the reason it's important to know this is because often when we have biopsies and they want to know the depth of invasion of the carcinoma, sometimes the orientation is not so good, and depending on what sort of vessels you have, you can call it either intramucosal carcinoma if it's confined to the mucosa, or if it goes down into the submucosa, you will see these large submucosal vessels. So thicker vessels tells you that you are in the submucosa. So that's another thing to remember. And we also have not just the blood vessels, but we also have lymphatic spaces. So here you can see that this is these are lymphatic spaces. And so here this is a blood vessel, and lymphatic spaces, these are most likely lymphatic structures. And the lamina propria tends to be sort of loose connective tissue. It's not as compact. All right, now we'll go on to the next slide. So this is so that was what we saw was the proximal and the mid esophagus, which is lined by stratified squamous epithelium. And then now we're going to come to the gastroesophageal junction. And another thing I want to point out about the muscle layer in the proximal esophagus, it is skeletal muscle. And then as you go down deeper, it is smooth muscle. Okay, so Daksha, will you continue with description of the second slide?
Yes, ma'am. So here we can see on the left is the esophagus, that it is lined by stratified squamous epithelium. So eventually when we go towards the right, so there is a transitional epithelium, so where we can see the transition from stratified to columnar epithelium. And next is below that we can see lamina propria, which has glands, and usually here there are 3 muscle layers in stomach, whereas there it was 2 muscle layer where we see in muscularis externum, and also we'll see adventitia.
Yes, okay. So yeah, that's right. That's very nicely described. So, and can you also talk about the glands that we have? So what kind of glands do we have in this lamina propria here in the mucosa?
Brenner glands. Brenner glands.
Yes. So Brunner glands we see it in the esophagus, and Brunner glands have this appearance of these sort of light, sort of transparent mucinous glands. And so here what we see, sometimes we see a combo of these mucinous glands. So do you see how this the cytoplasm here is nice and transparent? And then we also see these very pink and purple glands. And you see that the lumen is really small, right? Compared to this lumen, which is pretty big. These are smaller, more compact glands. And these are parietal cells. So the way I like to remember it is parietal cells are pink. So these are parietal cells and chief cells. And so these are oxyntic glands. And oxyntic glands are typically seen in the fundus of the stomach and in the body of the stomach. So the majority of the lining of the stomach is actually oxyntic mucosa. So this is the cardia, right? So this transitional point is the esophagus. So here we have the distal esophagus lined by stratified squamous, and then this very abrupt transition to the cardia of the stomach where you have columnar mucosa. And you'll see that this columnar mucosa here, it's a single layer of nuclei here, and sometimes it looks pseudostratified. There's also some tangential sectioning here that makes it look like that. So here, when we look at this layer here, we have nice apical cytoplasm, apical mucin, And so this is what we call foveolar epithelium. So foveolar epithelium refers to gastric type epithelium. So columnar foveolar type epithelium. And then you see here in the lamina propria, there are a lot of inflammatory cells, right? So what types of inflammatory cells do you see, Daksha?
Plasma cells, we are able to see, ma'am. And some mucin cells.
Yes.
Most predominantly it's of plasma cells, what we are seeing here.
Yes. And then here do you see
Other
some
than
cells with nice bright,
eosinophils.
exactly. So we have some eosinophils. These are lymphocytes. Lymphocytes kind of look like ink dots, right? Ink dots, and plasma cells have this eccentric nuclei. So it's a little bit more busy than the lamina propria of the esophagus, and that's normal. Well, I shouldn't say normal, but expected. It's expected in the cardia because it's almost always inflamed like this. It doesn't mean that there is anything pathologically significant going on. So what I want you to remember is that in the cardia mucosa, we have both mucinous glands. So here you can see nice mucinous glands, which have a very transparent cytoplasm. And we also have oxyntic type glands. Oxyntic glands are pink because they have parietal cells. And then here we have the muscularis mucosae, submucosa with your thick submucosal vessels, and we have the muscularis propria. And the stomach actually does have a serosa. So here in this particular slide, we're not seeing it because it's been ripped off, but the stomach does have a serosa, so it has a serosal lining. And then again here, between the muscle layers, you do see your nerve bundles, and here we have some ganglion cells. So those are all the normal features of the gastroesophageal junction. Okay, so now I will stop sharing the slides and let me just share some of my PowerPoint slides. Okay, can you see the PowerPoint?
Yes.
Okay, so just to recap, some points that I want to make about the normal histology is that the anatomic gastroesophageal junction is different from the histologic.
Could you go to slideshow mode, ma'am?
Oh, yes, of course. Yeah, there we go. Okay, so the anatomic gastroesophageal junction is basically the physical meeting of the distal esophagus and the cardia of the stomach. So it's like a single point. And that is sometimes the same as the histologic squamocolumnar junction, sometimes it's not. So the histologic junction is also referred to as the Z line, which is what the endoscopists will describe on the endoscopic, on their endoscopy. They might say the Z line is irregular or regular. And so there is proximal displacement of the squamocolumnar junction in conditions of injury, and most commonly in reflux or Barrett esophagus. And so this is similar to what we see in the cervix, right? So there's migration of the normal squamocolumnar junction in the cervix as well. And so here, you know, we have our esophagus, and this point right here, where this sort of angle where you have the esophagus meeting the cardia of the stomach, this dotted black line, that's your gastroesophageal junction. And then do you notice how the squamocolumnar junction actually is shifted up? These two lines may not be identical. So that's something to you know, remember. And when you look at the endoscopic image on the right, here you'll see that we can easily identify gastric mucosa, gastric tissue, because it has these the rugae, the gastric folds, and then it is more pink and velvety compared to the squamous mucosa here, which has a more of a pale white tinge to it. And then so here you can see that this is the what I'm following right here is the Z line, which is the squamocolumnar junction. And so this point here, right, where you have a narrowing of the lumen, that is actually the physical gastroesophageal junction. So again, here, we're not seeing this squamocolumnar junction go all the way down. So when we talk about, some common things to think about when you're looking at GI biopsies. So, when we are grossing, it's very important to formulate a grossing plan, knowing what the clinical history is and knowing what the anatomy and the radiology looks like. But on the other hand, I think for biopsies, it is best to look at your biopsy blind without the clinical history or the endoscopic impression to bias you. So when you first get your slide, just look at it without knowing the clinical history. Sometimes, you might need some clues. So it's okay to ask the question, okay, is this for a medical sort of biopsy? So am I thinking about reflux? Am I thinking about eosinophilic esophagitis? Or is it more a biopsy for a mass? So is it medical or mass? But otherwise, best to look at your biopsy blind. And then also think about what kind of tissue you're working with. Is it a biopsy? Is it an EMR, an endoscopic mucosal resection specimen, or is it a excisional biopsy or a polypectomy? So what is the procedure? And then does your tissue also, is it concordant with the designation? So suppose the biopsy says this is the proximal or mid-esophagus, but what you have is columnar mucosa, then you want to make sure that you have the right specimen. And sometimes there's also a designation according to the distance from the oral cavity. So they might say, so the normal, the average esophageal length is about 40 centimeters. So they might say esophagus at 38 centimeters, esophagus at 36 centimeters. So see if that is concordant with what you have on the histology. And always when you look at a biopsy, when you're looking at the histology, first try to identify normal tissue. And look at low power first, which is crucial to assess the architecture and overall behavior. And go to high power only when you have a somewhat of an idea of what the overall architecture is, and high power to assess the cytology. And for most neoplasms, we want both architectural and cytologic alterations. And then after you have a histologic impression, then you can look at the clinical history, why they did this biopsy, and the endoscopic impression to narrow down your differential. So in the GI world, some of the words that we use, I wanted to quickly recap. So metaplasia is not neoplasia. So metaplasia is a precursor lesion, but it is not neoplastic. It is just replacement of one cell type to a different cell type. Neoplasia, on the other hand, is a clonal aberration. So neoplasia, when you have a chronic injury, the first thing that the body does is try and adapt by metaplasia. And if you have continuing injury, then you have repair and proliferation. When you have more proliferation, you have a higher chance of a mutation. And when you do have a clonal a genetic alteration, you have a neoplastic proliferation. Dysplasia is a word that we use in GI land. Sometimes we also use it in the head and neck lung. Dysplasia means neoplasia. So dysplasia is in situ, which means it's intraepithelial or confined by the basement membrane. And dysplasia, generally, we have a two-tier classification system, either low grade or high grade. And it used to be a three-tier classification system. We used to say, mild, moderate, severe, but now it's simple and we just say low grade versus high grade. And in the esophagus, we can have both squamous, because we have stratified squamous epithelium, and we have glands and ducts. So we have squamous or glandular dysplasia. And carcinoma happens. Adenocarcinoma implies that there is invasion. So invasion beyond the epithelial basement membrane. And then we'll talk about intramucosal adenocarcinoma in a little bit. Okay, so we'll go on to our next case. And next case, I think Uday is going to be discussing the features with us. So
Yes, ma'am.
both case 3 and 4, So let me give you a quick clinical and endoscopic finding. So this is a 60-year-old male with history of chronic acid reflux. Now his PPIs are not working very well and he has worsening heartburn. And on the endoscopy, what we're seeing is the salmon pink, the velvety salmon pink mucosa that's extending into the distal esophagus. So here the white is squamous epithelium and the pink is columnar epithelium, and you're seeing that we have a very irregular Z line, right? So previously we saw that a more regular Z line. Here it is quite irregular, extending into the distal esophagus. Okay, we will now go back to our slides.
Ma'am, while we are switching the slide, there is a question in the chat box where
Yes.
what exactly is the meaning of esophageal ducts?
Okay, yeah, that's a great question. So I don't know in these slides if there are esophageal ducts. Let's go back. So in the esophagus, we have esophageal submucosal glands. So here we have our submucosa, right? So here's the muscularis mucosae, here's the submucosa, and we have submucosal glands. So they would be somewhere here. And sorry, this slide does not have it. But submucosal glands are not seen in the stomach, right? So here, for example, in the stomach, when you look at your glands, these glands are in the lamina propria. So that's mucosal, right? So this difference between where the glands are, so you see submucosal glands, then you know that you're in the esophagus. So that is helpful for identifying histologically what the site is. And then from the submucosal glands, you have a duct system to, let's see if maybe on the other slide. So you have ducts to carry the secretions from the submucosal glands into the lumen. And so sometimes you might see ducts, and ducts, sometimes you might see them in the muscularis mucosae, you might see them in the lamina propria. So those ducts also help you decide whether your specimen is from the esophagus or if it is from the junction. Okay, hopefully that was clear, but these maybe when in our other slides we might see examples and I'll point those out. But esophageal glands are submucosal, cardiac stomach glands are within the mucosa.
Thank you.
Okay. Uday, do you want to start describing this case?
Yes, ma'am. Here we can see HN slide shows mucosa with glands. Here we can see some, we are able to see some cystically dilated glands, which are lined by round cells and have clear to bluish cytoplasm. We can also see nuclear enlargement and stratification at places.
Yes, yes. Agree. So there's quite a bit of that. And then let me just go to the other piece. And then what do we also see here? So in this mucosa here, what are these cells?
This must be, these are the goblet cells.
Yeah, yeah, exactly. So we have goblet cells. That's right. And not too many goblet cells here. So this is this was a biopsy that was called gastroesophageal junction. So typically when you see a gastroesophageal junctional biopsy, you're expecting to see both squamous and columnar mucosa. But in this biopsy, we only have columnar mucosa, right? There is no squamous component. And this columnar mucosa We have these glands in the lamina propria. They're mucinous glands, like you said. And then we also have background goblet cells in the columnar mucosa. So does normal columnar mucosa in the cardia have goblet cells?
No, ma'am.
Yes. So, and what do we call this condition?
Intestinal
It's
metaplasia.
direct intestinal
Yeah,
metaplasia.
exactly. Yes. We have goblet cell or intestinal metaplasia, and then we also have some atypia in these glands. So once you have Barrett esophagus, so Barrett esophagus is a clinical pathologic diagnosis. So, in the endoscopy, they saw the mucosa extending, columnar mucosa, the velvety salmon pink mucosa extending into the distal esophagus. And on histology, we are seeing goblet cells. So goblet cells are, they're scattered within the columnar mucosa. And these goblet cells are reacting to injury, most commonly because of reflux, acid refluxing from the stomach into the esophagus. And so to deal with that, the columnar mucosa is not equipped, the squamous mucosa of the esophagus is not equipped to deal with that sort of damage. So it needs the columnar mucosa to sort of better maintain the epithelial integrity. Okay, and then so like you said, we also have changes in the epithelium. So you mentioned that it is hyperchromatic, they are enlarged. So this is not normal. And so does it look reactive or does it look dysplastic?
Dysplastic.
Yeah, I agree. This does look dysplastic. So when you look at it at low power, doesn't it look exactly like a TA? Right? It looks like a tubular adenoma in the colon. So that's the sort of look. It looks very blue. We're barely seeing any apical mucin. And, there is some inflammation, you see. So we have some neutrophils in the epithelium. So you might say, oh, maybe that's just reactive change. But this is too much. This is too much for just reactive change. So when you look at something in low power and it reminds you of a tubular adenoma, that is good for low-grade dysplasia. So here, so this is dysplasia. And then we want to categorize it. Okay, is this low-grade versus high-grade? So Uday, how would we tell the difference between low grade and high grade?
Looking at the mitosis, ma'am.
Mitoses can sometimes help. You might see more mitotic activity. You might see atypical mitoses in high grade. And generally, so there are two things you want to look at. So in low grade dysplasia, the architecture is still maintained. So you see, and when I say the architecture is maintained, you still see lamina propria between these glands, and you can still identify them as glands. And then when we look at the cytology, so like you said, there's hyperchromasia, there's enlargement. Sometimes you might see prominent nucleoli, but prominent nucleoli doesn't immediately tell you that something is neoplastic. In fact, when prominent nucleoli are more commonly seen in reactive or reparative changes. So we have, and then, we have mitoses here. And but the thing too that I want you to notice is that when you look at these nuclei, they are still polarized to the base. So these nuclei are all, you can still tell, okay, this is the bottom and this is the top. So here again, if you look at this gland here, we have preservation of the nuclear polarity. So the nuclei are at the base, which is normal. So those are all features of low-grade dysplasia. But then when you come to this area here, this looks quite different, right? So, here a lot of it is low grade, but when you look at this, so again, here, preservation of the nuclear polarity. But then when you come to these glands here, they look quite different. And here, Nuclei, some of them are on top, some of them are at the bottom. Here, and there's marked variation in the size and shape of nucleoli. Like, look at this cell. This is a really abnormal looking cell. And some are not even forming proper glands. Like, so if you look at this here, that's not really forming a true gland. So something like this would be high-grade dysplasia, and not just high-grade dysplasia, it is also invading into the lamina propria, right? So when you look at these cells, they have an infiltrative border. It's not a nice smooth round gland. So what would you call this, Uday? This sort of these sort of glands, this portion of it? So your options are low-grade dysplasia, high-grade dysplasia, or intramucosal carcinoma.
High-grade dysplasia.
I agree. So this is at least high-grade dysplasia, and I think we can say it's highly suspicious for intramucosal carcinoma. And you're not wrong if you say high-grade dysplasia, but I think some people might also say that this is intramucosal carcinoma. And there's quite a bit of variation in the criteria depending on which part of the globe you're from. So in Japan, they would call this carcinoma. In Europe, most of Europe, they would call this carcinoma. In the US, we have somewhat of a higher threshold to call it. So I think for this, we would say high-grade dysplasia, and then we also have some singly infiltrating cells. So those are highly suspicious for intramucosal carcinoma. So the difference between dysplasia and carcinoma is the fact that carcinoma is invasive, whether it's invasive into the lamina propria, goes outside of the mucosa, invasive into the submucosa, into the muscularis, or beyond into the adventitia. The depth of invasion is different, but it's critical for you to understand that the difference between dysplasia and carcinoma is the invasion. So it's not confined by the basement membrane. Okay, so here, again, to recap, so this is a good example of low-grade dysplasia, right? It kind of looks like your tubular adenoma, and your nuclei are still at the base. And then you come to other areas. Let's see if we can find more high-grade areas like this, where it's not so clear which is the top, which is the bottom. It's more jumbled, so there is loss of the nuclear polarity. And again, here we have some low-grade features, background, Barrett esophagus. So Barrett esophagus, once we diagnose, it's important to then say, to clarify if there is dysplasia or not. So you'd say consistent with Barrett esophagus, or you can say columnar mucosa with goblet cells compatible with Barrett esophagus, and then negative for dysplasia, or low-grade dysplasia or high-grade intramucosal. So those are very important. Okay, so we'll go on to the next slide. Okay, do you want to describe this one too? There, it's very similar to your previous slide.
Yes, ma'am. Here you can see section polypoidal mucosa with dysplastic epithelial line comprised of hyperchromatic elongated nuclei focally arranged in pseudostratified pattern at places. At places, mitosis is also seen, and stroma shows inflammatory infiltrates of lymphocytes, plasma cells, and eosinophils.
Yes. Yes, and we have background goblet cells. Yep.
Goblet
And
cells.
again, yes, again, here we have more goblet cells. Goblet cells have, they have sort of like a little bit of a bluish tinge to the cytoplasm, like a blue-gray tinge to the cytoplasm. And then okay, so you've said, I agree, you've said that this is dysplastic. Now, how would we classify this? Is this low grade or is this high grade?
This is also high grade, ma'am.
What about this particular piece? Yes, this one does have high grade, but not in this particular piece. So here we have preservation of nuclear polarity. So, so still we can still see that, okay, this is the bottom because the nuclei are at the bottom. And then at the top, we have we have this mucin here. So, so this particular portion is, I would say this is low grade. And then your higher grade component is like this. Right, so here there's it's very jumbled. It's really disorganized. So again, compare this one with this gland here. So this gland here, we have preservation of the nuclear polarity, and here it's jumbled. So this area is high grade. So we have a mix of both low and high grade. So this one here is low grade, and here, this is more high grade. It's getting a little bit more disorganized. And here again, this is high grade because it's getting disorganized. But the important thing to recognize is that, we have dysplasia for sure. And here, what about this? So this looks like your tubular adenoma, right? And so here there is polarity. Here, this is low grade. Here, this is more high grade because it's, again, these are small glands and there is loss of polarity. Here, again, this surface is very jumbled, it's disorganized. A lot of the times, the junctional mucosa has a lot of inflammation. So you need to be careful about, okay, is this just reactive change or is this dysplastic change? But, these changes that we've seen so far, these are very much dysplastic. Here's a lovely mitotic figure there. Okay, so let me just show you a different slide. Oh, okay, never mind. That was a better example, but that's okay. We will continue. Okay, so now we'll move on to slide number 5.
Ma'am, before we go to the slide, ma'am, we have two questions. One is, how do we differentiate between high-grade dysplasia and in situ carcinoma?
Okay, hold on. Let me. So high-grade dysplasia and in situ carcinoma, they are pretty much the same thing. So high-grade dysplasia, it is the same thing. So some people might use, and those terms can be used interchangeably. Okay, so just to recap here, so here is our normal epithelium, right? And we have this very abrupt transition to low-grade dysplasia. And high-grade dysplasia, you can see that these glands get a little bit smaller. It looks a lot more jumbled. When you look at this particular epithelium here, you can't tell which is the top and which is the bottom. And here we have, this is not just high-grade dysplasia, it is carcinoma. And we're calling it carcinoma because there's infiltration into the lamina propria. Another clue that you have invasion is when you start seeing this luminal necrosis. Do you see how we have some cells that are just falling apart? We have some pycnotic nuclei, very pink cytoplasm. So these are dying cells. And this is luminal necrosis. So kind of like comedonecrosis that you see in colorectal or breast cancer, right? So if you see luminal necrosis, that is an indication that now it's progressed beyond just high-grade dysplasia to invasive adenocarcinoma, so invasive into the lamina propria.
Ma'am,
And yes.
Other question is, ma'am, how to differentiate between reactive ATP and low-grade dysplasia?
Yes, yeah, that's a great question. So this is a really useful clue, what we call the 4 lines. So, so if you look at this image here on the right, so here this is our normal columnar mucosa, right? On top we have this foveolar mucin. So the apex of this foveolar mucin is your first line. The base of the mucin is the second line. The third line is this cytoplasm, and the fourth line is the nuclei. So you see these sort of 4 parts of the epithelium. And so these 4 parts, you'll see that they are preserved when you have reactive changes. On the other hand, when you have dysplastic changes, these lines, you can't really identify, okay, so if we go to this one here, so where you have low-grade dysplasia, we can't really see the foveolar mucin, right? We can't really see a good distinction between all of those 4 lines. So there is blurring of these 4 lines. So that is a useful way to differentiate between reactive or low grade. And again, when there is surface maturation, there is and preserved cell and nuclear polarity, abundant lamina propria around glands, all of these factors favor negative for dysplasia. And sometimes, we can't tell if it's reactive versus dysplastic. So another feature of reactive is that, you have a lot of inflammation, and you have a lot of active inflammation, neutrophils in the within the epithelium. So the questions you want to ask yourself when you're thinking, okay, is this reactive or is this dysplastic? First, okay, is there surface maturation? So do I see the 4 lines? So what I mean by surface maturation is the fact that you see all of these lines, you see the normal architecture of the epithelium. And then is there inflammation? So these 2 questions, is there inflammation? Is there surface maturation? And if there's a lot of inflammation, what I mean by inflammation is active neutrophilic inflammation, then you should be careful about rendering a diagnosis of dysplasia. And, sometimes it's hard to tell. We don't know if it is reactive or dysplastic. So in that case, what do we use the term indefinite for dysplasia. And indefinite for dysplasia, tells the gastroenterologist that, okay, listen, there's a lot of inflammation, so this could be reactive, this could be dysplastic. I can't tell just based on the morphology. So, they will usually wait for between 3 to 6 months, and then, maybe treat the patient if they have inflammation, if there's some infection, treat for Helicobacter maybe, and then come back in 3 to 6 months. And if you still have those changes, that would not be a good sign. Then you would favor it's a more dysplastic condition. On the other hand, if the inflammation has reduced and these changes have gone away, then it was reactive. So it's okay to use the term indefinite for dysplasia. And often, when you have this term indefinite for dysplasia, you want to show it around to your colleagues, get a fresh set of eyes to look at it before deciding something is indefinite. But indefinite is sort of a term that we use when we don't know. And sometimes it's okay to not know if it is reactive or dysplastic because we simply can't tell. You could use IHC to help you. IHC with P53, which is a tumor suppressor gene, sometimes can be helpful. It is more often mutated and aberrant in high-grade dysplasia rather than low-grade dysplasia. So if you're trying to decide, okay, is this reactive or low-grade, P53 immunostain might not be very helpful. On the other hand, if it is aberrant, then it can help you, but it's not always aberrant. So sometimes P53 helps, sometimes it doesn't. Okay, so let's go on to the next case. Anab, I think you're doing the next 2 cases, right?
Yes.
So a 56-year-old male with heartburn, chest pain, chronic cough, and on endoscopy, we have irregular erythema. So here you can see this black arrow here, and here is squamous mucosa because it's white. And we have this erythema, some erosion maybe, and ulceration in the distal esophagus. Okay, so let's go to our slide review. Let's try this again. Hold on just a second. Okay, we'll go on to the 6th case actually. I'm having trouble trying to log in for the other slide. Okay, anyways, so Anya, do you want to describe this this particular?
Yes, ma'am. This is section studied shows esophageal mucosa lined by stratified squamous epithelium, and it appears hyperplastic along with the elongation of retipex, and there is increased number of eosinophils in the lining epithelium. And there are few eosinophils which appear degranulated too. So,
yep.
And the surface, like this lining epithelium, also appear edematous.
Yes. Okay, and then what about the surface? What about the surface here?
Ma'am, like bit ulcerated.
Yeah. Yeah. And when we have more than 4 or 5 eosinophils together, you could call it a microabscess, right? So yes, so we have surface microabscesses, and like you said, lots of eosinophils. So what do you want to call this?
Eosinophilic esophagitis.
Okay, so that is, so eosinophilic esophagitis is a it's a disease characterized by increased eosinophils. So are there other diseases that also have intraepithelial eosinophils? Like other common conditions?
Ma'am, and allergic like causes or parasitic infestation.
Drug hypersensitivity.
So if you know, let's
Viral
say
infection.
50, what's that?
Viral infection में cytomegalovirus.
Viral infection generally tends to have neutrophils. And so eosinophils, so if you see intraepithelial eosinophils, 2 things you should be thinking of: reflux, so acid reflux, GERD, so gastroesophageal reflux disease, or EOE, so eosinophilic esophagitis. So both these conditions can have intraepithelial eosinophils. And eosinophilic esophagitis tends to have more. It usually has more than about 50. But I just want to highlight the fact that between reflux and EOE, there is no histologic changes that are pathognomonic. So you might have some features that sort of push you one side or the other, but really, if you had to look at this, you can't really say with certainty that this is either reflux, GERD, or EOE. So, so you know, we have this elongated vascular papillae, like you said, and then we have lots of we have spongiosis, the sort of like lace-like pattern. So why do you have spongiosis? What is happening to make these cells stand apart like this? So it's edema. So you know we have Yeah, so there's injury and there's edema. So the edema is what is causing the cells to sort of split apart. And so you have this sort of, it's almost like a lace-like pattern. And then you see, you can even see these, the cell junctions, because squamous epithelium is cohesive, right? It likes to be like a nice compact sheet of cells. And here, and the cell junctions, you can see them, they're really beautifully highlighted by the edema. So we have spongiosis, we have elongation of the vascular papillae, and we have lots of intraepithelial eosinophils. And we also have intraepithelial lymphocytes here, and you might also see some neutrophils, but the predominant inflammatory cell is eosinophils. So this could be either reflux or eosinophilic esophagitis. Now, based on the clinical history, we can decide, okay, maybe this is one or the other. So in the clinical history, if you see that the patient has heartburn, the patient is somewhat of an older person, and you have changes more in the distal esophagus. So like we saw on the endoscopy, there was erosion, erythema in the distal esophagus. So if it is more in the distal esophagus, what do you favor? Do you think this could be reflux or EOE?
Reflux.
Absolutely, yeah. So if it is more distal involvement, because you have acid coming from the stomach back into the esophagus, so it's going to hit your distal esophagus first, right? On the other hand, eosinophilic esophagitis, it is an allergic disease condition, and it is, and these allergens are usually directed against antigens, so foods that we eat that might be allergic. So food comes from top to the bottom, so it starts coming from proximal to distal, and often when you have, so the changes in EOE are more prominent in the proximal and mid esophagus. So and then of course, if you have, and there are also distinct endoscopic changes. So let me just quickly show you that. Okay, so this is what eosinophilic esophagitis would look like. So notice how, do you see we have these sort of like rings, almost like these are, it almost kind of reminds you of the trachea with the cartilage rings. So this is what we call trachealization of the esophagus. So we have these rings, and then you see these like vertical furrows. So these sort of like little erosions as vertical lines, and you might see some little bit of these furrows as well. So these, or these white patches. So when you see a ringed esophagus or trachealized esophagus with these vertical furrows, and these changes are seen more in the proximal esophagus, it's usually a younger person, and they have history of other allergic conditions, then it's more likely to be EOE. On the other hand, if it is reflux, here you see the changes are in the distal esophagus. You have erythema and erosions. You're not really seeing the tracheal rings. So, all these endoscopic findings are seen usually in the classic type. You don't have to see them. You don't always see them every time. Okay. Okay, so reflux esophagitis, to recap, we have spongiosis. And the other thing that you see is the basal layer hyperplasia, where you have increase in the basal layer. And I'll when I go back to the slides, I'll highlight that. We have elongation of the vascular papillae. And normally the vascular papillae come up to only about 1/3 of the thickness of the epithelium. And then, in the case that we saw previously, the vascular papillae were almost all the way up to the top of the epithelium. So that's abnormal. And you might see some congestion within those vascular papillae. Intraepithelial eosinophils, you do see in reflux, and they're usually less than 50, 20 to 50 usually. And with EOE, it's much more. You see intraepithelial lymphocytes and balloon cells. The balloon cells have a sort of frosted glass appearance. And when we get to the slides again, I'll show you. So eosinophilic esophagitis, on the other hand, usually you have more than 50 eosinophils, proximal or more diffuse involvement rather than distal, and superficial microabscesses like we saw in the case, marked basal layer hyperplasia, and lamina propria fibrosis is also would favor EOE. So again, none of these features are diagnostic. It would only sort of favor EOE over reflux. Okay, let's look at one more case of EOE. Okay, so these are the surface microabscesses, and if you go back to our normal esophagus, so here the vascular papillae, do you see how short and stubby they are? Usually they come up to maybe 1/3 of the epithelium, but in our case that we saw, it was going all the way up to the top. And this is the basal layer where it is, so these are the regenerating, it's the regenerating layer. This is where the stem cells are. And so the basal layers, the nuclei are much bigger and the nuclei are very blue. And as you go up, the nuclear size becomes smaller and you have a lot more of the cytoplasm. So the bottom, which is the basal layer, looks a lot more blue and the superficial layers look more pink. So, and you see that, so that's what we call basal layer hyperplasia, where you have a lot more of the basal layer cells. So here you can see this basal layer hyperplasia. So here is another case of esophagitis with increased eosinophils. Anab, do you want to describe this again?
Okay, yes, ma'am. This is again section study shows esophageal mucosa lined by stratified squamous epithelium. Shows hyperplastic lining epithelia with edema over the surface epithelium, and there is increased inflammation, like neutrophils, eosinophils, and okay, and there is also elongation of retipex, like vascular papillae.
Yes.
Here, and I think basal cell hyperplasia is also here. It's also present.
Exactly. Yes. Yes. Yeah. And so this is a case of EOE. And then I just wanted to show you how, you know, actually here in this case, we don't have that many eosinophils within the epithelium itself. But you see, like on the surface, we have all of these exudates full of eosinophils. So a lot of surface microabscesses in this one. And the other thing also is, notice how the lamina propria here in this case is it looks very thick, right? The lamina propria usually is nice and loose. It looks more white. It has more sort of empty space. And here the lamina propria is fibrotic. So lamina propria fibrosis is also one finding that you'll see more in EOE rather than reflux. Okay, so let's go on to our next case. Okay, so we'll go to our PowerPoint to look at the endoscopy images. Okay, and I think Shubham, this is, no, I'm sorry, this is Shubpreet. Shubpreet is going to be your case, right?
Yes, ma'am.
Okay, so this is a 56-year-old with progressive dysphagia. He's a smoker. He has a significant alcohol history, has some chronic cough, and they did an endoscopy which shows really a nearly circumferential mass, almost involving 8 centimeters, so a large exophytic tumor of the mid and distal esophagus. And you can see that it's exophytic, has a very irregular surface, almost looks like we have these horns, right? Like almost like those squamous horns, and some ulceration on top. And then let's go to our slides. Okay, Shubpreet, you wanna do this one?
Yes, ma'am. Ma'am, sections show mucosal epithelium lined by keratinized stratified squamous epithelium showing surface ulceration at places, and there is seen full thickness dysplasia, and one of the foci seen tumor cells invading the basement membrane. Tumor cells are arranged.
Yeah.
Yes, ma'am. And ma'am, tumor cells are arranged in nest and sheets and scattered singly, and showing mild to are medium to large in size, and showing vesicular to hyperchromatic nuclei and moderate amount of eosinophilic cytoplasm. Few mitotic activity also seen, and there is seen intracellular bridging, individual cell keratinization, and keratin pearls are also appreciated. And tumor cells are surrounded by inflammatory infiltrate and desmoplastic stroma. And my impression is well differentiated keratinized squamous cell carcinoma.
That was a beautiful description. Thank you so much. Yeah, absolutely right. So this is squamous cell carcinoma, and not just dysplasia, high grade or in situ. It's invasive because it's out of the epithelium, right? So here, if you look at this spot right here, we have these very infiltrative edges, and here we have this two cells that are singly that are infiltrating and have lost the connection to the epithelium. So this is, and here a really nice, beautiful keratin pearl. And there's, it's really disorganized. Some areas where you're like, okay, this looks like squamous mucosa. So when you can recognize it as squamous mucosa, then you can call it well differentiated. And if you're having a lot of trouble deciding if it's even squamous mucosa, that's when you would call something poorly differentiated.
Yes.
And if you're somewhere in between, there are some areas with keratin pearls, some areas that are more ugly looking, that's when you'd call it moderately differentiated. So I agree, this looks like a well differentiated squamous cell carcinoma. And we'd have some ulceration, and like you said, there's full thickness dysplasia. Here we have some ulcer with some bacterial growth, some colonies growing here. But yeah, this is a pretty straightforward squamous cell carcinoma. And look at that atypical mite there. That's beautiful. Lots of mitotic activity. And this also goes with the, based on that gross impression, it also looked like a carcinoma based on that gross impression. And for squamous cell carcinoma, sometimes the depth of invasion is important, but in a biopsy, often it's very difficult to do that because we have just bits and pieces of tissue, and it's not well oriented. Okay, so the next one is number 9. I think Minu, this was your case?
No, ma'am. Maybe 9th case was the one that is shown as 11.
Oh, I see. Okay. Shubpreet, do you want to take this one again, or I can take it if it wasn't assigned? Okay, so here this, so the history was, maybe this is let's say, I'm making up all of the histories. So this is the 30-year-old male with, he has some heartburn, and then incidentally they saw a nodule in the proximal or mid-esophagus. So here, when you look at this, it's very spiky, right? It's kind of verrucous looking. And we have hyperplastic squamous mucosa. Here are your vascular papillae, but very hyperplastic. And we have these spires and verrucae. And when you look at the cytology of these cells, it's quite bland. It looks very different from the cytology of the squamous cell carcinoma that we just saw. There is still appropriate maturation. So when I say appropriate maturation, what do I mean? So I mean that the epithelium is sort of growing in a manner or proliferating in a manner that is normal. So you have the blue basal layer, and then as it goes up, the nuclear size becomes smaller, it gains more cytoplasm. And then these nuclei, they stop being round and they become flat, and eventually on top you actually lose the epithelium. So that is normal squamous maturation, and we have preservation of the normal squamous maturation. So here, why does it look like this here? So it's hard to identify, where the top is and where the bottom is, right? Because these look like basal layer, these look like more superficial. So why does it look like this? What's going on here or here? So is this real, or is this an artifact of sectioning? It's an artifact, right? So yeah, exactly. So this is tangential sectioning. So this is something to be aware of, like in any biopsy, really. Sometimes you're trying to find a normal part of the biopsy, but you're having trouble, or, so when you have things like this, you can't come up with a diagnosis, right? So imagine if our entire biopsy was looking just like this. It would be very difficult to come up with any sort of diagnosis. So sometimes when you have tangential sectioning, it's not possible to come up with the right diagnosis. And you can say something like squamous mucosa with tangential sectioning, which precludes definitive diagnosis or something like that. But thankfully here, this is a well-oriented piece, and we see these verrucous projections. So this is a benign neoplasm. This is a squamous papilloma. This is a squamous papilloma. So we'll go back to our PowerPoint. Okay, so squamous cell carcinoma, this squamous dysplasia, again, when you classify dysplasia, you can say low grade or high grade, and high grade includes in situ dysplasia, so or in situ neoplasm. So for squamous dysplasia, it depends on what the epithelial thickness is that's involved. So if it is less than half, then we call it low grade. So here's an example of low grade where you see, so this top over here, this is somewhat normal. We have like a little bit of maturation going on, right? So this is low grade, but on the other hand, like all of the base and the bottom half looks disorganized. So that is low grade. On the other hand, over here on the right side, the full thickness of the epithelium is abnormal and dysplastic. So this is the high-grade dysplasia. It's still confined by the basement membrane, right? So we have the basement membrane at the bottom. Basement membrane is essentially a thick band of glycoproteins. So it's a good barrier for neoplasia. So that is crucial. So when we're thinking between dysplasia and neoplasia, dysplasia is still confined by the basement membrane. And so that's why this is not invasive. And then sometimes, we can have radiation effect. Sometimes some chemotherapy agents can cause similar effects. It's not neoplastic. So remember that we won't go in through all of the details, but remember that there are other conditions like, that could just be reactive or because of a therapy effect. And so dysplasia, generally, it doesn't have too much inflammation. And squamous cell carcinoma, it's not so popular, not so common in the Western world. And here adenocarcinoma is a lot more common. But adenocarcinoma is still on the rise in many parts of the world. But squamous cell carcinoma, also remember that what we saw was a really nice, well-differentiated squamous cell, a classic or a conventional. And sometimes you can have variants like basaloid, it can be more spindled, papillary, and verrucous. And some of the IHC markers for squamous differentiation are P63, P40. P40 is more specific, and CK keratins 5 and 6, so the low molecular weight keratins. And if you had to pick one immunostain, I would pick P40. And if it is spindled, it's also a good idea to rule out melanoma. So melanoma, you would do an S100, melanA, or a SOX10. Okay, so case 7, I'm not sure who was assigned case 7. So this is a 56-year-old woman with breast carcinoma and staging CT. So she was undergoing imaging for staging, and that detected an esophageal mass. So you can see that it's really nice and round esophageal mass. And an endoscopy, they thought maybe this was a lipoma, possible submucosal nodule. Okay, we'll go to slides. I think 7 was Shubpreet as well. Was that your case, Shubpreet?
Yes, ma'am.
Okay, let's go to our. Okay,
Yes,
get away. Do you want to describe that?
yes, ma'am. Ma'am, section shows mucosal epithelium lined by non-keratinized stratified squamous epithelium showing irregular thinning and hyperplasia at places. Subepithelium shows sheets of polygonal cells which has abundant granular eosinophilic cytoplasm with few skeletal bundles and thin vascular channels and mild nuclear pleomorphism and no mitotic activity appreciated. My impression is benign granular cell tumor.
Yeah, excellent. Yeah, so this is a classic example of a granular cell tumor. And this, what I want you to appreciate is that, it is, this epithelium, sometimes the squamous epithelium can look very atypical, right? Like when you look at this, it almost looks like there's some abnormal keratinization going. These nuclei look a little bit enlarged and disorganized. So we call this this sort of effect, and that's because the architecture is being disrupted by this mesenchymal neoplasm. The stromal neoplasm is creating those, it's secondary to the neoplasm. So this is what we call pseudoepitheliomatous hyperplasia. And it's important to recognize because sometimes when you get a biopsy, you get a very superficial biopsy. So imagine if you just got a biopsy of this, you could totally think that you're dealing with a squamous dysplasia. Important to also, make sure that you have sampled the lamina propria. So that's why the, being aware of what the endoscopy showed is so important, because if we didn't have the endoscopy report, we might think, oh, okay, this is just squamous dysplasia. But the endoscopy said this is a submucosal lesion. And if there is no lamina propria in our biopsy, we have to say, the endoscopic impression of a submucosal lesion is noted. However, this biopsy has no lamina propria or submucosa, right? So we can't evaluate when you have a superficial sampling. So that's why the understanding what the endoscopy is and why they did this biopsy is very important. And so like Shubpreet mentioned, we have this very bland looking cytology, right? All of these nuclei look very similar to each other. No significant nuclear pleomorphism or mitotic activity. And what are these, why is it so granular, the cytoplasm? So what do we have inside the cytoplasm that makes it look like this in a granular cell tumor? Any guesses? So these are lysosomes. So we have a lot of lysosomal, cytoplasmic inclusions made of lysosomes. And so that's why it's granular. And one thing about the granular cell tumor is notice how very hard to actually see cell borders, right? So it's very difficult to say where one cell starts and the next cell ends. And granular cell tumors are possibly Schwannian cells. So they have neuroectodermal differentiation. Let's go to our PowerPoint. And usually you see it more in the dermis or subcutis, so skin, head and neck, oral cavity are more typical sites. This is a rare tumor, but it's one of those things where if you see the pattern once, you should recognize it. And in the esophagus, in the GI tract, it's most common in the esophagus. Sometimes you can see it in the stomach. And like we talked about, the overlying squamous mucosa can have marked pseudoepitheliomatous change. And so should be careful not to overdiagnose it as squamous cell carcinoma. And because this has neural origin, S100 SOX10 is positive. You can also do some special staining. PAS with diastase treatment will show these lysosomes. And it's negative for HMB45, keratin, and desmin. Because in this location, when you have a mesenchymal neoplasm, you want to rule out a GIST, you want to rule out a leiomyoma. And also when you have something more spindled, melanoma, and mesenchymal lesions like alveolar soft part sarcoma can also have this similar histologic appearance. Okay, we'll go on to the next case. So the next case is 9 and 10. That was Minu's case.
Yes, ma'am.
50-year-old male with uncontrolled diabetes. He's malnourished and has uncontrolled diabetes, and endoscopy shows multiple white patches, plaques with a linear arrangement in the mid-esophagus. Okay, so here is our slide. Sorry, my computer is slow today. All right, Minu, do you want to describe what we have?
Yes, ma'am. Section study show fragments of stratified squamous epithelium showing ulceration and shows numerous fungal organisms seen as budding spores and as pseudohyphae. The epithelial cells also show, few of the epithelial cells show intraepithelial neutrophils. Also noted a focal extracellular collection of neutrophils, necrosis and necrosis, no atypia or malignancy seen in the section study.
Yeah, I agree. So what does this look like? And with this history of a middle-aged person with uncontrolled diabetes and malnutrition. So what is this likely to be?
Candida esophagitis.
Yes, exactly. So this is candidial esophagitis, very nicely described. So here you have your squamous epithelium, and then you can see that on the surface we have and you don't even need a GMS or a PAS for this to come up with this diagnosis, right? So here, like you said, we also have intraepithelial lymphocytes and neutrophils, and then more importantly, you see these hyphae, these fungal hyphae that are not just on the surface but infiltrating the epithelium as well. And so when you have fungus, you want to you want to describe what sort of excuse me, you want to describe what sort of fungal elements you have. So do you have yeast forms or do you have hyphal forms? And that's really important because when you have only the yeast form, that actually suggests that it's oral contamination and not true infection. But on the other hand, only when you have these hyphae, right? So an hyphae that are, so here, like these, so these guys here. So you see nice hyphae. And, you know, at this power, it's not really possible to say if these are true septae within the hyphae or if they're just like pseudo-hyphal forms. But when you see hyphae, that suggests that that is tissue invasive infection. And if you have only yeast, then it's oral contamination. So important to recognize what sort of form of fungus that you have. Okay, we'll go on to the next slide. Okay, how about this slide?
Sections show fragments of stratified squamous epithelium showing ulceration. Individual squamous cells show molding, multinucleation, and margination of nuclei. Multinucleation of nuclei with margination of chromatin. Few of the nuclei show homogeneous ground glass inclusions. Also noted as dense mixed inflammatory infiltrate composed of neutrophils, lymphocytes, and areas of hemorrhage.
Yeah. So, and then here you see, so let's try to find a good inclusion here. Here we go. So here, this squamous epithelium is really abnormal because, like you said, we have multinucleation, molding. What is molding exactly?
The shape of the cell nuclei change to accommodate the shape of the adjacent nucleus.
Exactly. So these, yeah. Yeah, so it kind of fits together nicely like a puzzle, right? So all of these nuclei are molded to the contours of each other. So here's a good one. So this is, we have molding, we have multinucleation, we have molding, and we have margination of the chromatin. Like here, for example, so margination, so you see this like nice prominent, sort of outline of the nucleus. So that's margination. So what are these three features tell you that this is? What is this? What is the diagnosis?
Herpes simplex virus esophagitis.
Yeah, exactly. So this is herpes esophagitis. And here's another example. So herpes infects the other ones too. We don't really have multinucleation in this one, but we have the margination here. And like you said, we have those sort of ground glass appearance of the chromatin. And all of these squamous cells are really falling apart. There's necrosis and debris. Here is another beautiful inclusion, multinucleation, molding, and margination. So this is herpes simplex. Here's another one. Herpes simplex esophagitis. It can be either herpes 1 or herpes 2. And the thing to remember about herpes is that it affects only the squamous cells. So let me go back to our PowerPoint. So let me plug in my charger. Hold on. Okay, so Candida, you want to mention if there's yeast, not just yeast, but also pseudohyphae. Neutrophils, hyperkeratosis, and parakeratosis are clues. So the case that we saw is a really florid example. So if you see intraepithelial neutrophils, hyperkeratosis, and para, then you can get a PASD and a GMS to show the fungus. And here is HSV esophagitis, which affects only squamous cells. And here is another viral infection, CMV, so cytomegalovirus, infects the endothelial cells and glandular cells, so not the squamous cells. And so here you see the typical inclusions where you have nuclear enlargement. You sometimes see these inclusions as well, the sort of owl eye inclusions of CMV. All right, so let's go to the next part of it, the stomach, and this one we'll go through quickly. It's already about an hour and a half. All right, let's quickly do the normal histology of the stomach. And I believe that was...
I will, ma'am.
Yeah, Shubham?
Yes, ma'am.
Yeah. Okay, Shubham, if you want to tell us about the... so this is the fundus.
Yes, ma'am. This is a H&D stained slide of a part of stomach showing the layers of stomach like mucosa, submucosa, muscularis propria, and the serosa. In the mucosa, we are seeing the glandular epithelium with which is having the glandular cells and the fivula part with secreting mucus plugs in between the glands. The section is also showing the eosinophilic parietal cells and the basophilic chief cells in the mucosa glandular epithelium. Then we are having the lamina propria, and then the submucosa. In submucosa, we are having the loose connective tissue with vascular elements, and after that we are having the muscularis propria, which is consist of mainly of three muscle layer. The innermost is the innermost is the oblique layer, muscle layer. Then the in between is the circular layer, and the outer is the longitudinal layer. And at last we are having the serous layer of the stomach.
Yeah. And that was really nicely described. Thank you. What about these? What are these? Yeah, ganglion cells. So just like in the esophagus, between the muscle layers, we have our myenteric and Auerbach plexus, the nerve plexus, ganglion cells. And then also, some people say, like, I mean, this whole thing is a serosa, but you can also describe this as a subserosa, where a subserosa, where you have the connective tissue, and really the serosa is just this single layer of mesothelial cells, right? So it's quite amazing that we just have this single layer that's a barrier to carcinoma escaping. Anyway, so and then here is the submucosa, which has fat, which has loose connective tissue. And again, like in the esophagus, notice how submucosal vessels are much thicker than your lamina propria vessels. And here you can see lamina propria vessels. There's some congestion, and so they're just single capillaries. So this is your mucosa. So the foveolar epithelium, the lamina propria, and in the fundus, there's not much lamina propria because you see there's a lot of glands which are really tightly packed. So lamina propria in the fundus, we don't have too much of it. And then we have, of course, the muscularis mucosae. Okay, now what about the pyloric section? So either the pylorus or the cardia of the stomach.
Ma'am, this is also H&D section showing the layers of the mucosa, submucosa, muscularis propria, and the serosa. But here, in the parietal region, there are stroma to glandular epithelium is about 50 to 50%. This is the mucosa is also showing here the same chief and the parietal epithelial cells with some.
Oh, so hold on. So do you see the pink purple cells, or do you have more cells with mucinous type epithelium?
Mucinous.
Yes, yeah, mucinous, lots of mucinous glands. Okay, keep going.
Lots of the mucinous glands. Then we have the submucosa, and at last we have the muscularis propria and the serosa.
Yeah, exactly. Yeah. So the difference between the auxentic type or the body type of, or you can call it fundic type, is that instead of the auxentic glands, which are the parietal and the chief cells, we have these mucinous glands. And also in the antrum, notice how, we have a lot more of the, I'm sorry, this is here, we're all the way in the duodenum. Let's go up here. So if we're in the duodenum, then what do we call this? These are Brunner's glands. And how do I know? And how do I know this is duodenum? Because yes, and also we have, right, and we have goblet cells and villi. So that's duodenum. So here is more of your foveolar epithelium. Here are your mucinous cells. And notice how there's a lot more lamina propria, in the antrum. And then here's your muscularis mucosae, submucosae, muscularis propria, and the serosa, but looks like the serosa has been, here we go. Here's more, here is serosa. And in the subserosa, you have fat, you have vessels and loose connective tissue. So that is in the pylorus, and you have the pyloric and the antral duodenal junction here. And in the duodenum, we have the submucosal Brunner's glands. All right, and I will go on to I'll describe the next slide.
Ma'am, there's a question. Please
Yes.
explain about foveolar epithelium in the stomach.
Okay. So the foveolar epithelium is just the name given to the columnar epithelium in the stomach. So here is columnar epithelium, right? So we have the nuclei at the base, and we have this apical mucin. So this type of columnar mucosa with this very discrete apical mucin is called foveolar epithelium. So it's just a special name that we give the gastric epithelium. And here also you see foveolar epithelium. If we go to the pylorus or the antrum. So right here you see the columnar epithelium, and you see the apical mucin, right? So it's a really nice little apical mucin globule. So that is the foveolar epithelium. Okay, so I'll just go on to the next slide. And this is just it's a very common, it's not a pathologic alteration, but it's a very common finding. And so here, this particular piece, this is more antral type. We have these mucinous glands. We have more lamina propria. And then you come to this piece. This is very tightly packed, and this is oxyntic mucosa with the parietal cells and the chief cells. So here, what I want you to notice is, do you see some of these glands here have they have apical snouting? So this so normally it's a really tiny lumen that you have. And then if you look at some of these areas, you see that the lumen is dilated, and you have apical snouting. And so this is PPI effect. So when the patient has reflux, or when they have, they're trying to suppress the acid, so they're taking omeprazole or any other proton pump inhibitor. And so when you inhibit that, then the parietal cells want to keep producing more and more acid, right? So there's your feedback loop. So because you have, so that is exactly what this is. This is just parietal cell hyperplasia. And parietal cell hyperplasia is most often seen in the context of the patient taking PPI. So if you see this on histology, check their medications, and this is compatible with PPI change. Okay, we'll go to the next one. And in the interest of time, I will just tell you the history and endoscopy finding. Okay, so this is case 16, Arya. Arya's, this is your case? So
No,
this
ma'am.
is a
No, this is my case, Anisha.
Oh, Anisha, oh, sorry. So Anisha, if you want to describe this, so this is a 40-year-old woman, and on endoscopy, she has antral erythema and antral erosion.
Here we can see multiple tissue bits showing antral-like mucosa, which is lined by tall columnar foveolar epithelium with mucosal glands, and at places showing atrophy. And the lamina propria shows infiltration by inflammatory cells like lymphocytes, which are forming aggregates at places, and plasma cells and few eosinophils. And H. pylori is also identified here in 2 or 3 crypts.
Yeah, absolutely. That was a really nice description. So here, so what type of, where are we? So what type of glands are these? So is it mucinous or is it oxyntic?
Mucinous.
Mucinous, exactly. So if it's mucinous, then that means that this must be antrum, right? So yeah, so this is antral type mucosa, and like you said, we have our beautiful foveolar epithelium, lots of plasma cells. So lymphocytes in the stomach does not mean chronic gastritis, right? So you need to have lots of plasma cells. So when you see lots and lots of plasma cells is when we call chronic gastritis. And for active gastritis, what do you need to see? You need to see neutrophils. So let's see, and neutrophils not just in the stroma, but infiltrating the epithelium. So you need to see neutrophils. Exactly, yeah. So let's see. And usually when you have chronic gastritis, you also have, when you have marked chronic gastritis like this, you'll also see neutrophils. So there we go. That's a nice example, right? So there are some EOs over here, and here these are multi-lobed. So these are neutrophils. So this is active chronic gastritis. And like you said, we do have Helicobacter pylori, Helicobacter, I should say. And usually you find it, sometimes it's obvious even on H&E, and in this case, you could actually see it on H&E as well. Here you go, there it is. So here is a bacillus. So it's a rod-shaped bacteria, and it's usually stuck on either the surface or within the pits. It's on the surface. It does not invade the epithelium. And sometimes if you don't see it on H&E, you can get, what are some stains that you would get for diagnosing Helicobacter, to detect Helicobacter?
Gimsa and silver stains like Watson starry. And then we can go for Genta and quick diff quick.
Yes, diff quick. So many stains that you can use to highlight the organisms, and there's also an IHC stain. So what's the difference between using the IHC and the special stains? So the special stains will not only, so it doesn't tell you if it is Helicobacter pylori or if it is Helicobacter Hillmanii, right? So Helicobacter pylori is the more common one, but you should also be aware that there are other Helicobacter species, so Helicobacter Hillmanii, which is, you see it more often in cats, actually. But you can also have human infection. So when you do the Gimsa or the Genta, Wharton starry, you can say that there is Helicobacter. But if you do the immunostain, then you can be more specific and you can say, yes, this is, if your antibody is directed towards Helicobacter pylori, then you can say immunostain, is positive for Helicobacter pylori. On the other hand, if you're using Genta, it's more appropriate to say Helicobacter identified by Genta stain. Okay, so here's Helicobacter gastritis. So the way that I would sign this out is marked active chronic Helicobacter associated gastritis. And then what is the pertinent negative? What should we say that there is no, what should we say? Negative for?
No dysplasia.
Exactly, yes, no dysplasia. So if you continue to have, so if this patient doesn't get treatment, doesn't get triple therapy for infection, then what is going to happen? They're going to get intestinal metaplasia first. So we need to first say negative for intestinal metaplasia, negative for dysplasia. And if they continue to have infection, so the adaptation is first metaplasia, and you have more injury, you have dysplasia, you have more injury, it progresses to adenocarcinoma or hematopoietic neoplasm, which is maltoma. So there's your Helicobacter pylori. And let's go on to the next case, number 17.
Here we can see 3 tissue pieces. 2 of them are antral-like and one of them have auxentic mucosa. Here we can, the mucosa is lined by foveolar cells, but the fovea and the gastric pits shows irregularity and they're serrated-like and have a corkscrew appearance. And then the lamina, there is lamina propria shows expansion and with fibromuscular proliferation with few ectatic blood vessels, and there is no significant inflammation present in the lamina propria.
Yeah, excellent. So what do you want to call this?
Reactive gastropathy.
Yeah, reactive gastropathy. Yes. So this is biopsies of the antrum, and we know that this is antrum because here we have mucinous glands. And, this particular stain, it's looking a little bit more pink, but overall these are mucinous and not auxentic glands. And like you said, so the reason this looks really blue is because we have loss of the foveolar mucin, right? So when you look at this here, you see the nuclei and then on top you see the mucin. You go back to your atypical glands, you see that there is loss of the mucin. Some of it on the surface we have preservation, but like if you look at these, there's no apical mucin, right? So that's why, because the nuclei are really blue, it has a very blue look to it. And we have really long elongated glands, not much inflammation, there's lamina propria fibrosis, and these smooth, you can see a lot of fibroblasts and smooth muscle fibers. So this is a really good example of reactive gastropathy. And what is the etiology of reactive gastropathy?
Ma'am, chemical injury or drugs like NSAID.
Exactly, yeah. So, your usual clinical context will be a person who has maybe middle-aged person who has osteoarthritis. Maybe they have some sort of chronic pain syndrome, maybe some sort of rheumatologic illness, and they keep popping ibuprofen or they keep popping Tylenol. So this is the usual pattern of NSAID-induced mucosal injury. So this is chemical gastropathy. And so once, it's not an itis. So remember that gastropathy is not a gastritis and there's not much inflammation associated with it. Okay, let's move on to gastric polyps. This is a little bit of a complicated case, more of a 3rd year or 4th year case, but I think was it Anuradha? Is Anuradha? She was not here today, right?
Yes, ma'am. She's not here today, ma'am.
Okay. So let me describe this one. So this is a gastric polyp. And here what we're seeing is very disorganized, right? It's hard to make out, okay, where's the lamina? Where is the, where's the epithelium? Where is the muscularis mucosae? It's very disorganized. And then, you finally identify the epithelium. So here's our foveolar epithelium. There's a lot of foveolar mucin. So there's foveolar hyperplasia. And these, the gastric pits are very disorganized. Again, they're elongated, and there's edema in the stroma. We have, you can see how there's a lot of edema, there's some inflammatory cells, and let's go to the other piece. Here, so these portions. So this is a hyperplastic polyp. And this is not just a regular hyperplastic polyp. So hyperplastic polyps are usually because of a reaction, most commonly to Helicobacter infection or when you have some sort of injury, there's hyperplasia, there's epithelial regeneration and hyperplasia. So this is a hyperplastic polyp, but this was from a patient who had FAP, so familial adenomatous polyposis, which is a cancer predisposition syndrome, right? And so this is a really, so what does this remind you of? So in the colon, if you saw this, what would you call this? Anyone can answer. So if you saw this in the colon, what would you call? What kind of polyp? So is this, so in the colon, would you? Yeah, exactly. So you'd simply call this a TA, right? This is just a tubular adenoma. And so here, this is a really nice abrupt transition. So whenever you have abrupt transitions, that usually tells you that something is dysplastic. So this is dysplasia. And if we had this in the colon, you could call it a tubular adenoma. But we're in the stomach here, so now we can classify, is this low grade or high grade? And this is low grade dysplasia because you see here the nuclei are all at the base. You know, it's not, you can still say which the top is and which the bottom is. There's no loss of the nuclear polarity for the most part. So again, this is low grade dysplasia. So this is a hyperplastic polyp with low grade dysplasia. And usually hyperplastic polyps don't have dysplasia, but this particular case was from a patient with FAP. So they have a cancer predisposition. So they have not just colonic polyps, but also stomach or small intestinal polyps with dysplasia. Okay, we'll do 2 more cases and then we'll stop. Here is another polyp. Okay, and let's go to this piece here. So this is so we have dilated glands, right? So here on top we have foveolar epithelium, which looks a little bit abnormal, but we'll come back to that. But here, these are your oxyntic glands, right? So these are oxyntic glands lined by parietal cells and chief cells. And you see that some of the glands here are really dilated. They're very ectatic, completely dilated. And so this is a fundic gland polyp. Yes, yes, this is a fundic gland polyp. And this also is not just a regular fundic gland polyp because, again, when you look at the surface, this also has low-grade dysplasia. So I just put these 2 cases in here just to, show you that, when you have polyps, also make sure, and you have like one diagnosis, you're like, oh, okay, I have a fundic gland polyp and end of case. But also remember to evaluate for other features, especially looking for dysplasia. So this is a fundic gland polyp with low-grade dysplasia. So here, so let's go back. So here are your more normal fundic glands. And here is the dysplastic component, right? So if you look at this, if you saw this in the colon, you'd call this a TA. And again, if you had to describe it as low grade or high grade, and I would call this low grade dysplasia because we have retention of the nuclear polarity. And a lot of these polyps tend to be inflamed, right? Here you see some neutrophilic infiltrates, and that's because they are sort of flopping around in the stomach, they get irritated, and there is inflammation. So that's not unusual at all. But fundic gland polyp is dilation of the fundic or the oxyntic glands, and a hyperplastic polyp is dilation of the foveolar mucosa. Okay. Sorry, my presentation just suddenly stopped. Hold on.
No problem, ma'am.
It's like my computer is also realizing it's time for breakfast and coffee.
Right. I think
and dinner time for you guys.
yeah. So
Okay, we'll do one last.
do you want to go for one last case, ma'am?
Yeah, let's do one last case and we'll stop at 7:30.
Okay, ma'am. Meanwhile, I'll just ask a question. A question in the chat box is
Yeah, yes, please. Yes,
what is
yes, please.
Brunner's
Yeah.
gland adenoma and hyperplasia?
Okay, hold on just a second. So let me just show you that slide of the normal histology of the duodenum. So Brunner gland hyperplasia versus adenoma. So hyperplasia is not neoplastic. Hyperplasia, okay, so can you see the slide?
We can see like it's in low power. We can't see the now we can.
Oh, okay.
Now we can see. Okay.
Yeah. Okay, so here is our duodenum, and we have villi, we have goblet cells, we have these Brunner glands, which are mucinous glands. So and notice that most of the times in most of the duodenum it is submucosal, but it can come up into the lamina propria, so that's not abnormal. So Brunner gland hyperplasia is neoplastic, and a Brunner gland adenoma is neoplastic. So there is not sometimes the morphologic distinction between those two can be very difficult to make out. So generally we call something an adenoma if it has a more nodular profile. For example, when you look at this here, it has a more linear arrangement, right? It has a sort of spreading quality to it. An adenoma is going to be more encapsulated, it's more circumscribed. And in a biopsy, it can be quite difficult to distinguish between hyperplasia and neoplasia because we have such little material to work with. It's hard to see the lateral spread versus a circumscribed lesion. So usually, if they did a polypectomy, on the other hand, it might be easier to differentiate between the two. But on a biopsy, it can be difficult. And so for cases like that, what I would do is I would simply say with prominent, duodenal mucosa with prominent Brunner glands, see comment. And in the comment, I would say this could represent either Brunner gland hyperplasia or adenoma. And the distinction is challenging given the scant amount of material available or something like that. So in a biopsy, it can be difficult to diagnose, but might be easier on a polypectomy specimen or a larger specimen. Okay, so our last case. Okay, so this is a, let's say this is an 80-year-old person, 80-year-old female with anemia, and she's undergoing an endoscopy to see if there's any GI blood loss. Okay, so when you look at this, it's very busy looking. There's a lot happening. So let's go about it in a systematic manner. So here, this is, I can see that there is foveolar epithelium, and we also have some intestinal metaplasia. And then now I'm trying to figure out, okay, where am I? Am I in the antrum or am I in the body? So is this mucinous glands or is this pyloric glands? And this is maybe mucinous, but I'm not entirely sure. And when I look at this piece again, you know, all of this is foveolar epithelium. Maybe that's mucinous, but I'm not 100% sure. And if I go to this piece again, same case. It's not exactly clear to me where I am because it's hard to identify mucinous cells and oxyntic cells. So far, I haven't seen anything that looks definitively like oxyntic glands. But on my biopsy designation, the endoscopist has said I have biopsied both the antrum and the body, right? So there's a discrepancy between what the biopsy label says, what the specimen designation is, versus what we have on the endoscopy. So anytime you have problems identifying where exactly you are, and you see metaplasia, so there's intestinal metaplasia, this sort of pattern of injury should make you think about metaplastic atrophic gastritis, right? And so metaplastic atrophic gastritis can be secondary to autoimmune, or it can be secondary to environmental causes. So what we call AMAG and EMAG. So A for autoimmune metaplastic atrophic gastritis, or EMAG for environmental. And when we say environmental, it's usually because of Helicobacter pylori. So metaplastic atrophic gastritis means that there is atrophy of the oxyntic glands. So there's replacement of these atrophic glands. There is intestinal metaplasia, and there is usually accompanying inflammation. So here again, we have lots of chronic gastritis, lots of plasma cells in the lamina propria. We have our intestinal metaplasia. So we usually get a gastrin stain, and I'll show you the IHC. A gastrin stain will, this is chromogranin, a gastrin stain will highlight the antral pieces. So here's our gastrin stain. And if it is antrum, it will highlight G cells, which produce the gastrin. So here it is, you know, you have like one or two, but that's not enough. So basically we have no G cells. So if you have no G cells, that tells me that this is a fragment of body. So this is all corpus or body mucosa with oxyntic gland atrophy, intestinal metaplasia, and then another immunostain that we get in this type of scenario is chromogranin. And chromogranin is going to show us the neuroendocrine cells, including the enterochromaffin-like cells, so the ECL cells. So here you can see, and this is too many ECL cells. So this is, if you see here, normally you should just see like one or two highlighted. Here you see way too many cells. So this is ECL cell hyperplasia. So all these little nodules. So if the patient continues to have gastritis, autoimmune gastritis or Helicobacter gastritis without taking treatment, then these neuroendocrine cells will go from hyperplasia to neoplasia. So that's how you get neuroendocrine tumors in the stomach as a result of autoimmune gastritis. So here is a really great example. And this patient ended up having anti-parietal cell antibodies. So these are, so this is an example of autoimmune gastritis. So, and another way to think about this, sometimes it's described as antralized body mucosa, because when you look at this, you sort of think, okay, could this be antrum? You're seeing no body cell, no oxyntic glands at all. So you can say this is antralized body mucosa with chronic inflammation, intestinal metaplasia, and with ECL cell hyperplasia. All of this is compatible with autoimmune metaplastic atrophic gastritis. Okay, so I will stop here. And that's as much as our brains can handle at one point.
Thank you. Thank you so much. Yeah, there are no more chat questions in the chat box. That was an excellent session, and you were very patient with the students, and you explained really well. Like I'm a hematopathologist, but I was there throughout, so I could correlate that. That was like an amazing session. I'm sure the students and everyone has benefited out of it. And at the end of the session, also we have more than 100 participants. So that also shows that how beautiful this session was. So I would like to announce next talks that are coming up. Those on 13th Feb we have a talk on inflammatory bowel disease by Dr. Siddharth Dattagupta, and on 15th February we will have slide seminar on endoscopic biopsy of lower GI tract. That will be by Dr. Prasanjit Das. And stay tuned to our Telegram group to get updates about the sessions. Thank you so much. Thank you, ma'am. Thank you, everyone.
Thank you, ma'am.
Thank you, ma'am.
Thank you so much.
Thank you, ma'am.
Everyone. Thank you so much to Dr. Shweta and Dr. Kanyapan for moderating the session. And I'm really glad I got this time with you. All right. Thanks so much for interacting. Bye.
Thank you.
Bye.
Bye bye.
Bye, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you.